Hello, everybody. My name is Chichi Johnson, and for this presentation, I will discuss population health, obesity in adults with intellectual and developmental disabilities. From now on, I will be referring to them as IDD individuals. For this presentation, this is the table of content. Please feel free to jump around throughout this whole presentation, but these are some of the things that I will discuss for the presentation. The objectives for this presentations are to analyze data associated with vulnerable population like IDD population who experiences obesity. I will also utilize the nursing process to disseminate an intervention to you concerning health and illness parameters of obesity based on current evidence. I'm also going to utilize data collection, current literary evidence, and leadership skills in the development and implementation of nursing interventions specific to the health needs of IDD population. I will apply research and data analysis skills to address health disparities and healthcare delivery issues with this population. I will also design quality improvement interventions using diverse evidence-based strategies to address disparities in the IDD population. The prevalence of obesity and overweight adults is predicted to reach around 70% by 2030. The CDC in 2020 called obesity an epidemic. The World Health Organization called it a pandemic. Obesity is the next major public health challenge facing the United States. Currently, over 60% of the US population is overweight or obese. And the health consequences of obesity include increased rates of diabetes, hyperlipidemia, heart disease, and cancer. Obesity have surpassed smoking as the most pressing public health threat. In much the same way that anti-smoking campaigns were developed, health initiatives must now be developed to effectively prevent obesity and its associated diseases. While obesity and smoking share many similarities from public health perspective, obesity is potentially more problematic since adequate nutrition is essential for survival. So we can ask people to abstain from food. That's not an option. Also, what constitutes good nutrition as opposed to harmful food choices is often not clearly understood by the general public. So as changes to the healthcare system in the United States are discussed, plans should be offered that directly and aggressively target obesity through different health initiatives and prevention programs. In the United States, more than 72 million people are obese. That's like 1/3 of adults. The obesity rates are significantly higher among racially and ethnic groups. Non-Hispanic Blacks or African Americans have a 51% higher obesity prevalence. And Hispanics have 21% higher obesity prevalence than non-Hispanic whites. The annual healthcare cost of obesity for all adults in the United States were estimated to be as high as $147 billion for 2008. Now, you can imagine with 2021, it's even higher, especially during the quarantine where most adults and children stayed home with limited activities. So the obesity rate is higher. Of course, there's no statistics out yet for that. Individuals with IDD, intellectual disabilities, are particularly vulnerable population who are at risk for becoming overweight and obese. And as we go through this whole presentation, you're going to see why. The intellectual disability is a group of conditions that are portrayed by limited mental function and the complexity with adaptive activities such as daily living activities, social interactions, money management, daily schedules and practices. The disability can be cognitive, it could be physical, or it can even be both. Any intellectual disability that begins before the age of 18 may be due to biological origins, such as cerebral palsy, autism, Down syndrome, fetal alcohol syndrome, and non-physical issues such as absence of stimulation and adult receptiveness. If the cognitive, physical, or both disabilities occur before age 22, the disability could be severe and lifelong. According to the United States Department of Health and Human Services, people with IDD represent 4.9% of the Medicaid population and account for 15.7% of total Medicaid expenditures. A 2003 cost analysis estimated that the mental restriction is 51.2 billion cost. Cerebral palsy costs 11.5 billion, and hearing disabilities cost 2.1 billion, and vision impairment costs 22.5 billion. Compared to the general population, IDD individuals' lifespan is lower. Medical and technological advances have increased life expectancies for this population. However, compared to the general population, the average age for IDD individual is 65.5 years, as opposed to people without IDD that is for 85.3 years. So people with IDD have more chronic illnesses than people without disabilities. According to CDC in 2018, 38.2% of IDD individuals are obese, 11.5% have heart disease, 28.2% smoke, and 16.3% have diabetes. Adding to the social determinants of health, 13% of disabled people do not have high school degree, 59% are unemployed, 85% do not have internet access, and 34% have a household income of less than 15,000, or 34% have inadequate transportation. IDD individuals have several barriers. They have limited healthcare, access to healthcare. Their unavailability of healthcare professionals and service providers that are dedicated to or specialized for this vulnerable population. And this population lack adequate data collection. According to CDC, the studies found that 13.7% of IDD individuals have problem with ambulation, 10.8% have problem concentrating or remembering, 6.8% have difficulty with daily living, 5.9% have problem with hearing, 4.6% have problem with vision, and 3.7% cannot dress or bathe independently. The current health studies of this population is that they're more likely to experience a lot of complex health conditions. Their chronic illnesses are very poorly managed. They have limited access to quality healthcare and health promotion programs. And the mental health problems and potential overuse of psychotropic medication is very prevalent in this population. And of course, most of them are overweight or have obesity problem, and of course, all the problems that come with being obese. Further studies show that the health condition in this population, that 17 to 70% have epilepsy or neurological disorder, 33 to 63 have dermatological disorder, 11 to 43 has to 43% there are fractures or lacerations, 8 to 10% have gastrointestinal disorders, and 9 to 45% have cardiovascular disorders, and 21 to 49% have behavioral or psychiatric disorder. And of course, 10 to 99% have sensory disorders such as vision or hearing. So this population has a lot of chronic illnesses, limited access to healthcare, but has high healthcare cost expenditure and consume a lot of healthcare services. For the rest of this presentation, I am going to discuss some of the nursing leadership approaches and the causes and practice initiatives for the obesity in this population. What causes obesity? Well, there are many factors that can contribute to somebody being overweight or obese, such as high caloric intake, lower physical activity, greater use of psychotropic medication, limited access to community leisure facilities, or in case of this population, lack of skilled staff and day staff services, lack of dietary advice and lifestyle changes, and can be genetic. There may be genetic predisposition or even disease that can cause obesity. The world around us actually influences our ability to maintain a healthy weight. For instance, in some vulnerable populations, they may not have area parks, sidewalks, or affordable gyms. And this makes it hard for people to be physically active. Food, if you go into some of the vulnerable population neighborhood, there is fast food everywhere that serve oversized food portions, making even more physical activities harder, especially if the person is overweight. To actually get out to exercise may not be available since they don't have enough environmental places to exercise. Some people in this in this vulnerable population may not even have access to supermarkets that sell affordable, healthy foods, such as fresh fruits and vegetables. And if they may have advertisement that encourages them to buy unhealthy foods, such as high-fat snacks and sugary drinks. And if you look at genetics, research showed that genetics play a role in obesity. Genes can directly cause obesity, such as Prader-Willi syndrome, and some hormones may cause overweight and obesity, such as underactive thyroid or Cushing's syndrome, or even polycystic syndromes. In this population, with the IDD population, they may have medications that may cause weight gains like steroids, antidepressants, or even seizure medication. Some people eat more than usual when they're bored, angry, upset, or even stressed. Studies have found that the less people sleep, the more likely they are to have overweight and obesity. And this is partly because the hormones that are released during sleep help control appetite and the body use of energy. Obesity leads to many adverse effects and low quality of life. And depending on the cause of obesity, the cure may not always be available to some people because of finances, or because of they don't have the resources for exercising or eating healthy. According to the United States Department of Health and Human Services in 2004, they listed the strategies that might help the communities to lower the risk of obesity, and of course to lower obesity. Some of these strategies that communities should increase availability of healthy food and beverages, and that communities should improve the availability of supermarkets in underserved areas. And communities should improve availabilities for purchasing food from farms, and provide incentives for production, distribution, and procurement of foods from local farms. Communities should restrict availability of less healthy food and beverages. They should institute smaller portion size in public service venues. They should limit advertisement of less healthy foods and beverages. Communities should discourage consumption of sugar-sweetened beverages and should promote and support increase in breastfeeding, as breastfeeding have shown that it will limit fat gain in children. They should require physical education in schools and increase the physical education programs. Communities should increase the opportunity for extracurricular physical activities and reduce screen time for children and of course, even for adults. Communities should improve access to outdoor recreational facilities and enhance infrastructure supporting bicycling. They should support infrastructure supporting bicycling and supporting walking and supporting exercising. Schools, locating schools within easy walking distance of residential areas will support walking and exercising. They should improve access to public transportation and enhance personal safety in areas where people should be safe to exercise and be physically active. Communities should enhance traffic safety in areas where people should be physically active. And they should participate in coalitions and partnerships to address obesity. The rate of obesity in people with intellectual and developmental disability is generally higher than the rest of the population. The population level prevalence data show that obesity level in people with IDD are either similar to or higher than non-IDD counterparts. Obesity in this population is particularly higher in women, older individuals, and those with less severe disabilities and certain genetics that causes obesity, such as Down syndrome. The literature examined the body weight of over 1,100 individuals with IDD who resided in group home and several community-based residential programs. Overall, 15.6% of men and 25.1% of women were obese. Individuals with mild and moderate limitation reported a higher rate of obesity than their counterparts with profound and severe limitation. They also found that in general, obesity was more prevalent in older individuals with IDD for both genders. A variety of factors have been suggested by literature as likely to increase the risk of obesity in people with disabilities, but that some of these can be modifiable. So they can be modifiable to target obesity so that quality of life can be improved, and of course decrease some of the healthcare costs that are associated with being obese. The IDD population that live in the United States and live in group homes have a significantly higher obesity rate than other countries. So these differences support the theory that the environment appears to have a powerful influence on the obesity in this population. So obesity presents a substantial threat to the livelihood of people with IDD and may have an effect on community participation, independent living, and healthier years of life. However, the literature kind of have a gap that, there's a lack of research on successful weight reduction strategies for IDD individuals that are obese. So there's a lot of research that is needed in this area. The literature also show that people with disabilities can find it more difficult to always eat healthy, control their weight, or be physically active. And this might be due to lack of healthy food choices, difficulty with chewing or swallowing, or with the taste or texture of food, or they may have medications that can contribute to weight gain and weight loss and changes in appetite. Physical limitations that can cause a person's ability to exercise. Some of them may have pain, they may lack energy or lack accessible environments such as sidewalks, parks, or even exercise equipment that will enable them to exercise. The lack of resources such as money, transportation, or even social support from their caretakers, friends, families may also contribute to obesity. Well, research show that physical activity exercise level among IDD are considered generally very low. They have limited access to healthy food choices and exercise venues such as fitness centers. Again, this can be due to resources like money or transportation to get to the facility. Immobility is a predictor of mortality and life expectancy related to activity in those with severe intellectual disabilities. So studies show that physical activities reduces mortality and morbidity, especially in coronary artery disease, hypertension, obesity, osteoporosis, and even mental health disorder. And all these conditions, as we saw from the previous slides, are increased in intellectual disabilities. Studies suggested that friendships and opportunities for social activities could have a stronger effect on body weight status of people with Down syndrome than just regular diet and physical activities. And also literature inferred that a person living environment, that is, they have a friend who can socialize with them or have access to leisure and recreation programs in the community, might be as critical as diet and physical activities in addressing obesity among IDD. An understanding of other environmental factors that affect physical activity, participation, and caloric intake, such as having safe communities, safe sidewalk that are not broken up or non-existent, different walking or biking paths, attitudes of families and support staff can be very instrumental in reducing obesity and overweight in this population. The literature also talked about that the traditional approaches used to promote weight management within this population are limited. Okay, the literature indicates that a multi-component approach is required to produce significant impact in the area of weight management in this population. Assistive technology will provide potential for multi-component interventions that can promote change in health-related behaviors, and this will help with managing weight. So for this presentation, looking at the previous slides and what literature suggested, I believe that an inclusive, healthy communities model would be appropriate to manage this obesity in this population. So the inclusive, healthy communities model promotes disability inclusion strategies and make healthy living easier for all people across community sectors. And that includes like in schools, in the workplace, in healthcare, in group home. In other words, wherever the patient live, learn, work, play, pray, receive care, this model will work. The model uses a phased approach to create a local level change by using community collaborations and collusions to plan and implement a sustainable, healthy living improvement. So through policies and systems and environmental changes, this model focuses on increasing access to healthy living opportunities, such as healthy eating, physical activities, general accessibility improvement, and even tobacco use prevention and cessation. So the 6 phases of inclusive healthy communities include commitment to the opportunity to want to lose the weight, assessment and training of all the people that will help, all the stakeholders involved, prioritization and planning, implementation of the program, evaluation and communication and dissemination. This phased approach helped the community coalitions to navigate through different activities to achieve local level impact over a multi-year project period, typically around 3 years. The public health professionals also use this model to build inclusive communities that help to improve the health and well-being, especially for population like this IDD population. So the current approaches to creating a healthy communities for people with IDD require greater involvement in the part of the direct care staff and family members to facilitate increased access to healthcare lifestyles like healthy living activities, community inclusion activities, including more opportunities for regular physical activity and greater access to nutritious and tasty and affordable food. So environment is far more complex for people with IDD because of some of the limited issues that they have, like mobilities and supervision and all that. So it's very imperative that support staff step in because they can make a difference in the choices and the activities for this population. Another thing is using active and passive movement, like dancing, passive movement in beds and other activities. So some special services may be necessary for those who cannot access services. So if they have limitation with mobility, they can get passive and active exercise at home. So environment shouldn't be a barrier to stopping getting healthy activities. In case of some IDD population that have financial constraints like money and transportation or geographical access, again, there should be strategies to bring this to and resources in the community to avoid these constraints. So a truly facilitating environment is one in which the health promotion is available. So in making physical activity, healthy food, and nutrition accessible for all people. Another thing that for this proposed intervention is nutritional risk screening that will provide a systemic approach to improving recognition and management of nutritional problems that might be in this population and that could benefit them. So screening for screening for nutrition related problem could be performed by anybody working with the developmental disability population. However, it's important that if any problem is found, that they should be referred back to professionals like registered nurses and nutritionists. There are tools that are available for this assessment. It's a simplified screening tool that is used for, to check for weight and weight change, eating abilities, general appearance, and even simple assessment of their food and fluid intake. So some basic knowledge of nutrition and knowledge of access to a referral system is needed. And the criteria for referral should be clear and as specific as possible. Simple and safe nutrition intervention should be applicable. So with basic nutritional education materials. So it's important of teaching the bedside, the direct care workers who may not have that nutritional education, but teaching them what to look for and referring them to the registered nurse and the nutritionist. Individuals IDD individuals that have persistent underweight or overweight, eating or drinking problem, or chronic constipation, or specific medical condition will be among those that will need systemic assessment. So again, referring as needed to a dietitian, registered nurse, or even their providers. So for the inclusive healthy model, this program the proposed program will make sure that the direct care staff and family members are trained to know what to look for. The individuals will be offered opportunities for regular physical exercise and activities. They should have access to nutritious food that is affordable and that is tasty. They should have environmental barriers should be eliminated. And of course, having regular nutritional risk screening is needed. So for the goals and objective of this proposed intervention is to develop strategies to decrease that obesity rate for IDD individuals in group home. So the sufficient evidence, as we saw in the previous slides, recommend that these adults with disabilities should get regular physical activity. Right there, there are 4 key interventional approaches for obesity: focus on the dietary intake, physical approaches, looking at increased energy expenditures, health promotion and health education approaches, and of course, using that multifaceted approaches to incorporate more than one of the interventions that I mentioned. So implementing any change requires knowledge of change processes and team building and creativity and innovation and collaborative skills. So with this proposed intervention, the residential managers should contact the families and the guardians of the IDD individuals before even the implementation of the project. Before the implementation, consideration and assessment of the organizational readiness to change, their culture, the communication channels, the systems, assessing the potential staff and any institutional barriers to the change is needed. They're instrumental in the project's success and sustainability. So that will be done first to make sure, to get the buy-in. So getting the organization ready for the implementation involves collaboration, support, an entire team's buy-in, and identifying the project's champion, the formal and informal leaders, and stakeholders. The comprehensive assessment information will be provided to all stakeholders, and to show them to convince them about the need for a change, and to answer questions and correct any misinformation, any misunderstandings about the proposed change and the processes and the investigation of the current practices, how that will change, how this proposed intervention will change the current clinical practices. And so it's that initial phase is time to, opportunity to address some of the gaps, and of course, promote all the stakeholders' need to think critically. So with the objectives, weekly we'll implement an ongoing exercise program for all IDD individuals as tolerated, depending on their disease processes and their disabilities. And of course, start introducing healthy eating habits daily, monitor for nutrition-related problems annually. The project planning tool from Institutes for Healthcare Improvement will be used. The project planning tool will be initiated at the beginning of the project. This tool has been tested and validated by other organizations seeking to make changes. This tool will be used to plan the project. The form will help track the project team to, to think analytically and to track the project changes, including the plan, do, study, plan, act cycle will be implemented, the timeline, the responsible persons for each project objectives. According to Institute for Healthcare Improvement, the PDSA CA will be combined with the project planning form to measure, plan, implement, test, and refine any changes. The key stakeholders will be all non-clinical and clinical staff. And I want to include, the reason why is that the whole agency has to change and everybody has to be on the same, understand the objectives and the goal of the proposed intervention for it to work. So everybody should be saying and doing the same things. This workshop will also monitor ongoing and concluded measures or any identified variances. Approaches for continuing data collection and measurement against benchmarks will be very vital in determining if there's any changes and if the changes are effective. Also, these two help with the ownership, responsibilities, and accountability of the new change. It will be assigned, so everybody will know what they're supposed to do. Of course, as the improvement continues, the team members should be held accountable for their tasks at the different stages of the process. The tool will also monitor any communication about the change, any needed support and training, and of course help to sustain the change, because it will involve monitoring for compliance, for the feasibility of the intervention, and the need to standardize the improvement. And of course, it will help to revise any barriers, any effect on the workload of the organization, give an ongoing timeline and monitoring that is essential. So another thing that is very important is getting the leadership team buy-in will help to facilitate the project. Again, this will help with the implementation and of course getting resources as needed. And the executive team will be convinced using evidence-based research and metrics to highlight the patient safety and the return of investment of this proposed intervention. The managers and the registered nurses will help to certify the ongoing implementation of the project solutions and ensure that the team members achieve goals while sustaining superior performance and collecting data. The stakeholders involved, meaning the whole agency, will also continue to gauge metrics against the established benchmark and ensure that every level of staff conform with the change process by entrenching that change as the new protocol and norm. In other words, will help to sustain and all the the goals and the objectives of the proposed intervention. The management team will continue to support and encourage the team until the change is incorporated in the daily practices. Also, there will be strategic reporting of the savings and costs to gain the executive team support and make the savings more objective and noticeable for all. For this action plan, I will be the team lead. And of course, I would need the interdisciplinary team of clinical and non-clinical teams that will help for the training and also for implementation of the proposed plan. On the top of this, I posted the objectives and the process measures, the percentages of what will be measured as the improvement is going on, and of course the goals that we intend to achieve. The timeline is there, and the responsible people are there that will be monitoring what they were supposed to do, the tasks they're supposed to do to prepare for the test. Finally, I also wanted to use the improvement logic model for this. And again, it's just the improvement logic model methodology will be used for the intervention, the evaluation, the analysis phase of the project. A logic model of the theory of change or theory of action is a visual image of how the initiative is expected to create anticipated outcomes. So this model will reveal outcomes of interventions, interrelationships, the influence of external contextual factors to produce and deliver an interventions, the activities that the intervention offers, and the expected result. Also, the model shows the interconnectedness and the reasoning of the cause and effect that leads to the desired outcome. So the improvement logic model methodology will facilitate the understanding of any complex intervention. It will guide the development of measures. It will clarify goals and gaps, track process and change need, and maintain a focus on intervention process and context. Every member will have input, activity, outputs, and outcome to deliver within a specific timeline. It's imperative to engage the team from the beginning. So an interdisciplinary team will be formed to gauge the team's buy-in of the change and monitor any barriers and enablers to the project. The team will consist of clinical and non-clinical staff. The roles and responsibility for each level of management and staff will be defined. A formal structure to define the lines of authority, communication, and decision-making. And this will help to ensure a smooth workflow for our proposed intervention. The aims, the objective, the timeline, the resources, the measure outcome will be explained to the team. The project will start with a pilot study of one of the group homes before generalizing it to the rest of the 22 group homes. The anticipation is that the study will take 6 months. The project will involve communicating the problems urgency to the 32 agency middle and executive leadership and agency staff. The nutrition, passive, active exercise training for the direct staff will be done by the nutritionist, physical therapist, and will be supported by the staff development team and nurses during off hours. The training will be uploaded to the agency's intranet for easier access. To meet the objectives, the monthly weight and food intake will be documented in the electronic health record flow sheets. And the data will be collected by monitoring the process measure and monitor for compliance. The team will implement the quality improvement plan. The week before the go live day, the primary group nurse and the nutritionist will review to ensure that the food choices are appropriate. On the day of the go live, the nurse, the staff development, and the nutritionist will be available during the day, afternoon, and evening meal times and community inclusion activities to answer questions, encourage staff and individuals. All staff will be instructed to email the team leaders any identified problems, unexpected observations, any positive and negative encounters during the go live event. This report from these key stakeholders will monitor any barriers or change or plan for the project's sustainability. During the PDCA cycle, results will be revamped and utilized depending on the feedback from the staff. Evidence-based literature will be presented to support the benefits of the initiative. And again, during this phase, collection and analysis of the data will continue. Feedback from the staff will yield qualitative data to measure their satisfaction with implementing the project. Initial analysis will be completed to ensure no breach of the assumption of normality, linearity, and homoscedasticity. Statistical analysis such as Pearson product moment correlation coefficient will be used to examine the relationship between the project and weight loss among the cohorts. Mann-Whitney test will measure the daily compliance of complying with the healthy food choices and exercises. The Wilcoxon signed rank will measure increase in medication for the obesity-related chronic illnesses before and after the implementation of the project. An independent sample t-test will be used to compare GI disorders before and after the project and to ascertain if any differences are statistically significant. So for the for this logic model, the inputs, the activities, outputs, and outcome kind of mimics the IHR, the planning form. However, in this case, all the inputs, what the nursing leadership, the interdisciplinary team will do, and the organization, they will continue to have that formative and process evaluation and outcome evaluation throughout the whole process. And of course, the outcome depends on how well the input and the activities, and of course the output that the team will do. And again, this is a quality improvement project. So of course, data will constantly be analyzed. And if any change, we'll go back to the drawing board until we get the results or the changes that is needed. For the budget, getting the leadership team's buy-in will help to facilitate the project's implementation and more resources to help with the plan of the project. So the changes, importance, and urgency will be explained to the senior executive and management team using evidence-based research and metrics to highlight the patient safety and return of investment. The cost-benefit ratio shows the association between the cost and benefit of the quality improvement project for analysis. The benefit cost ratio is measured by the projected benefit of the present value divided by the present value of cost. If the cost benefit ratio is more than 1, the agency will gain. And if it's less than 1, the agency will lose from the initiatives. So for this project, it is projected that the cost benefit that the cost benefit for this is going to be, okay. So for this, it's projected that the cost benefit ratio is 4. So the agency will gain, so it's a 4. The agency will gain, actually its cost benefit is 8. So the agency will gain from implementing the electronic, for implementing the exercise and healthy food choices for the IDD individuals. So the potential return of investment for this change is immense. The project implementation, the organization will use the internal resources, the internal workforce to offset incurring cost of hiring consultants or therapists or exercise specialists and all that, because they already have that in their workforce. An estimated budget of 0 indicates the importance of that collaboration with the leadership, collaborating with the leadership, because they will provide the resources and support for the implementation of the project. So it will reduce the cost that we usually would have incurred if we didn't collaborate and use the leadership team. So it's estimated that this project is cost effective with high return of investment. There is no financial obligation that will stem from this project. The project will use, like I mentioned, the internal resources such as staff development, trainers, therapists, nutritionists to train the staff and train the cohort. The time for staff training will be during the downtime when the IDD individuals are at day programs, walking or sleeping. So there will not be a need to pay staff or trainers for overtime or even hire additional per diem staff, because it will be planned so that everything is happening downtime time. The agency already have the equipment that will be used, and it's really not that much, just, walking shoes, community inclusion activities in areas that will allow for physical activity. The food purchase, there's already a food budget. So the food budget will be used to buy food that are healthier instead of foods that are not healthy. So there's not really any cost for this agency. Everything is internally. And actually, this agency is going to be saving a lot of money, especially if this project works. And we're going to discuss that in the next slide. What are the benefits to the agency? So the impact this program will have, as I mentioned before, the return of investment will be calculated by the decrease in the overweight individuals, resulting in fewer costs that is incurred from visiting emergency rooms or staff leaving due to injuries, or the agency's cost for correcting regulatory deficiencies and citations. So again, because you have decrease in body mass index and and obesity, that this cohort would be healthier, and that will lead to increased reimbursement. If you think about that value-based reimbursement from CMS, so there will be increase in reimbursement from healthcare payers, and the staff satisfaction would decrease turnover rates for staff. Again, this decrease will increase safety for the individuals, because they will have dedicated staff that know them instead of staff that are coming and going. They will have long-term staff that knows their need and know what they need. And again, with the decrease in sentinel and never events, will translate to the agency being competitive, and being and sustaining itself in the healthcare arena. So they will meet public health initiatives that will result in increase in reimbursement, increase in staff safety, and of course decrease in the healthcare expenditure for this population. So finally, how do we evaluate intervention? Well, I've talked about using the IHI and of course the logic model to kind of look at the interventions and to see if the program, did what we set out to do. However, there's a framework that can also be used. This framework is called the RE-AIM model. It's been used to understand the relative strengths and weaknesses of different approaches to health promotion and chronic disease self-management, such as in-person counseling, group education, and in this case, obesity reduction program. So the overall goal of the RE-AIM framework is to encourage program planners and policymakers to pay more attention to essential program elements. And that includes external validity that can improve the sustainable adoption and implementation of effective, generalizable, and evidence-based interventions. So the 5 steps to translate research into actions, again, that RE-AIM model will be reach. Did we reach the target population? In this case, the IDD individuals? Yes. Did the intervention reach most people, that the population that needed the most? Yes. The E is the effectiveness. Did the intervention affect the targeted outcomes? The intervention, did it accomplish its goals? Yes, the estimation is that yes, the intervention will accomplish the goal of the IDD individuals reducing their body weight. The A is the adoption. To what extent are those targeted to deliver the intervention? Did they prepare? Yes. If we engage the whole agency, the clinical and non-clinical staff, yes, it's estimated that if the staff, clinical, non-clinical, and of course, other stakeholders like family members, community, and of course, the executive team, that yes, this strategy, this proposed intervention will be adopted by 100% of the agency. And the I is the implementation. the extent to which the intervention was consistently implemented by the staff member. Again, if we follow the all the quality improvement measures, and we know how to change what to look for in staff and all the feedback, the loophole feedback, and everybody's accountable for their own task and all that, definitely will be implemented. And of course, will we maintain it, meaning sustain it? Yes, we will be sustaining it by making sure that we constantly go back, reevaluate, and trench it into the practices of the agency to make sure that everybody is following. And of course, we, no tolerance for not following good nutrition and exercise. The idea is that if it's entrenched and sustained and become part of the policies and protocol of the agency, that the likelihood is that it will continue. So the evaluation just, it focuses on solving the problem, collecting data, analyzing it, interpreting the results, and reporting the information. It provides feedback about changes of the problem, how and what needs to be improved, what needs to be measured. The evaluation must meet the 3 objectives of the project. So the evaluation should be measured during the intervention implementation, and at the end of the intervention, that it will yield qualitative and quantitative performance indicators. Okay, these are some of the references that are cited in the presentation. I hope that you enjoyed this presentation as much as I enjoyed giving it. And thank you for your audience.